All right, good evening, everyone. I'm Jennifer Telford, and I'd like to welcome you to the first colonoscopy education session of 2022. Just a reminder, we are CME accredited for this program for Section 1. We have three fantastic speakers tonight, two British Columbians and Dr. McIntosh, who's coming to us from Nova Scotia. They'll do approximately 20 minutes for each of their talks. And then we will go to a panel question and answer period, which all the speakers will participate in. You can put your questions into the Q&A box rather than the chat box, into the Q&A box. I will try and keep a line on the Q&A box as well. And just a reminder that this will be video recorded and available on our website later. So I'm going to start off just discussing adenoma detection rate in the colon screening program. This entire session is sort of focused around adenoma detection rate, which is timely as the colonoscopy quality reports will be coming out very soon. And as all of you have been participating in the program know, every year, each individual colonoscopist gets a colonoscopy quality report with their own individual data on it, as well as the averages for the entire province. And the adenoma detection rate, we calculate just from the colonoscopies that were done to follow up positive fit. So if you're seeing a patient in the colon screening program because of a high-risk family history or a personal history of precancerous polyps, they won't be included in the ADR. So although that does limit the numbers that are included in the denominator, it makes it quite a homogeneous population, because for an individual physician, those FIT positive patients should be sort of distributed fairly equally, we think, amongst the physicians who are participating in terms of their other risk factors that may increase that patient's individual risk of having an adenoma when you do a colonoscopy on them. We report them as unadjusted, and we only had unadjusted for many years, which means it's just the raw data. So the number of FIT positive colonoscopies that you detected an adenoma on over the total number of FIT positive colonoscopies you did. But we had some feedback around perhaps adjusting that for risk factors that we know can increase one's risk of having an adenoma. So in the colon screening program, we know the patient's their age, their gender, and their FIT value. Well, we think that patients will be fairly equally distributed, as I mentioned, amongst physicians, so that there shouldn't be a physician who's getting a proportion of patients that are higher risk or lower risk that could affect their ADR relative to the other colonoscopists in the program. There may be some geographic variation. And we did actually find when we adjusted it that some health authorities adjusted down to the mean because they tend to have an overall older population. So Island Health and Interior Health, most of those ADRs came down a little bit when they were adjusted, whereas Vancouver Coastal and Fraser Health, the ADRs went up a little bit because we have a younger population, just when you're comparing to the overall average for the program. The adenoma detection rate benchmark. So when we record these quality indicators, we want to compare them not to just how the province is doing, but to a benchmark to know how we're doing individually and as a group. And adenoma detection rate benchmarks, they're probably the most widely accepted ones, are the ones that have been generated in the United States. But those are based on primary screening colonoscopy, whereas our FIT positive population is an enriched population for both cancer and polyps. And so the benchmark should probably be higher than what's recommended on the primary screening colonoscopy population in the United States, which is an average of 25%, or 20% for men, or pardon me, 20% for women and 30% for men. We'd initially set a benchmark in our program of 50%, and that was based on the Canadian Partnership Against Cancer, which is a federally funded institution that has been very helpful in setting up meetings for the various colon screening programs across the country. And with contributions from all the screening programs as well as other stakeholders, they created several years ago now a quality indicator consensus document. And they had, we somewhat arbitrarily, because we didn't have data at the time on this, chosen 50% as the benchmark. So your ADR in a FIT positive patient, we'd initially said should be 50%. However, this really didn't take into account the geographic variation that can occur in colorectal cancer, and I'm sure adenomas even across our country. So where Dr. McIntosh lives in in Halifax, as well as the other maritime provinces in Quebec, they have a higher prevalence of colorectal cancer than we do in British Columbia. So we would expect that their adenoma detection rate and cancer detection rate, in the East would be higher than what we have in British Columbia. And in addition, with the FIT positivity cutoff, because ours is quite a sensitive cutoff, a lower cutoff at 10 micrograms per gram, our positive predictive value may be lower than other jurisdictions where the FIT positivity cutoff is higher. So we looked at developing locally our own benchmark that's really relevant to our population of interest, the citizens of British Columbia. And we're helped along by this by some great work that was done at the University of Calgary by Dr. Hilston and colleagues, including Dr. Heitman, who's spoken at our colonoscopy education day and in these sessions numerous times. And they looked at their colon screening center at developing a benchmark that was based on their population of interest. And so they would take the average for their entire population and make that sort of the benchmark or the lowest standard that should be met. And what they also explored in their study was the confidence intervals that are around an individual physician's adenoma detection rate. And we've reported the 95% confidence intervals around your mean adenoma detection rates, I think since the beginning of the colonoscopy quality reports. And this takes into account the variation around someone's ADR. So although we give you your mean, there's actually a range between your lower and upper confidence intervals, and we're 95% certain that it's going to occur somewhere between those. But there can be quite a big interval there, and the fewer colonoscopies that one does in the program, the wider that interval will be, because there tends to be more random variation. So we took the ADR benchmark on the most recent colonoscopy quality report, so last year, this year, upcoming years, to be the average ADR for all of BC, the minimum standard benchmark. And then those physicians who were considered to be meeting standards was where their upper 95% confidence interval was higher than the benchmark. Those that were exceeding standards was where their lower 95% confidence interval was higher than the benchmark. So not only was their mean higher than the benchmark, but their 95% confidence intervals, the lower one was higher as well. And that's sort of considered to be an aspirational ADR, one to strive for. And then those individuals who are not meeting standards, their upper 95% confidence interval was lower than the benchmark. And I'm just going to show you this on the graph. And so this ADR benchmark graph we all get on our colonoscopy reports. And so along the x-axis is all the colonoscopists in the program, and the y-axis is the adenoma detection rate. And for British Columbia for 2020, the report cards that are coming out, you'll see the ADR average ADR was 56.9%, so almost 57%. And we always have this distribution where you get tailing off at the bottom with the low ADRs, the high ADRs, lower numbers here of physicians generally, and then most people sort of sitting around this area. And the ADRs in this line here. And this individual, we have their unadjusted ADR here, and then they moved up when it was adjusted, mostly based on patient age. It gets moved up. So this individual probably tends to scope lower patients, at the younger aged patients compared to the provincial average, and their adjusted ADR did move up a little bit here, but here's the 95% confidence interval. So the lower interval is above the benchmark for BC. So this is sort of an aspirational. So this person is sort of exceeding the standards that we'd like. Someone who would be someone not meeting standards is where this 95% confidence interval, where they were sitting down here, and their 95% confidence interval was below the benchmark. But I always show that graph, so I wanted to show an aspirational one this time. So challenges for us and for you as well receiving these is that the colonoscopy quality reports are not timely. So the time it takes for us to get the data in from the hospitals, the pathology reports, to get this all data entered, we're receiving our reports, a year and a bit later. So we received our 2019 reports in the spring of 2021. So if I've had a low ADR in 2018 and I've And I got that report in 2020, and I worked really hard all through 2020 to increase my ADR. And then my next report comes out and it's still low because it hadn't been reflecting all of that hard work I'd done. It's discouraging, to say the least. So we are really trying to make some changes whereby, especially for people who are low detectors, we can get some data out to them in a more timely manner. So hopefully they can see that beneficial change to the hard work that I'm sure is being done after getting a report with a lower ADR. In addition, we aren't really crediting other findings. So adenomas are important, of course, but colon cancer is very important. And we know that cell-serrated lesions are important to detect as well. So there's other cancerous and precancerous findings that are important. And if my ADR is a bit low, but my cell-serrated detection rate is higher than the provincial average, I'd like to see that reflected as well. And so we will be making changes, which I'll show you in the next slide, to that. And lastly, these metrics only reflect colonoscopies we're doing in the colon screening program. And so obviously we all have practices outside the colon screening program, and it may be, if those were included, that we might see different results. But you have to have quite granular data in order to be able to calculate an adenoma detection rate, and we just don't have that for colonoscopies that are done outside the program. So get all your patients registered in the program. All right, so I'll show you in the next slide the total neoplasia and cell-serrated lesion detection rate we'll be reporting, and the timely feedback I said that we're working on, particularly for physicians who are not meeting the benchmarks. And here is sort of a draft of the colon screening quality report card that will be coming out soon for 2020. So these current results are 2020 here. And so, as I mentioned, we have the ADR that's unadjusted, and then the ADR here that's adjusted for fit value, gender, and age, compared to the benchmark. This is incorrect. The benchmark is the 57% that I showed you for this year. This was from last year's benchmark. We just need to change that. And then we added the cell-serrated lesion detection rate. Okay, so and we went back and calculated it for the previous year as well. So in our program, about 9% of patients who have a colonoscopy for positive FIT will have a cell-serrated lesion detected. And this is, if you have any adenoma detection, this is if you have any cell-serrated lesion detected. So these are not, you could have an adenoma and a cell-serrated lesion, and it would be counted in both of these. But the total neoplasia detection rate only counts any colonoscopy that has one neoplasia detected. So whether it's a colon cancer, an adenoma, cell-serrated lesion, it would count as that. So that's the total neoplasia detection rate that we'll be incorporating as well. So in our program, 61% of patients who have a positive FIT will have some type of neoplastic lesion resected, either malignancy or a cell-serrated lesion or an adenomatous lesion. And so those will be the changes that you'll see in the upcoming colonoscopy quality report. So I just wanted to give a little bit of background as to what we're doing in British Columbia before we move on to our talks. I'm just going to stop sharing, and then Dr. McIntosh can share. So our first speaker of the evening, I'm so delighted to see him, even if it is virtually, because we usually get to see each other once or twice a year at meetings, is Dr. Don McIntosh, and he is a gastroenterologist out of Halifax and a professor of medicine at Dalhousie University. He was one of the very early proponents and advocates for colonoscopy quality, and was really instrumental in bringing the global rating scale for endoscopy to Canada, and was one of the founders, I guess, and developers of the skills enhancement in endoscopy course, which many individuals, many of you perhaps, have taken in British Columbia, the colonoscopy skills improvement course, which is excellent. We always get great feedback on. So very happy to have you here. Donnie's going to tell all of us how we can increase our adenoma detection rate.
Thank you very much. Can you hear me?
Yes.
Good. Okay. Thanks, Jen. I really appreciate the invitation to join you guys. It's great. A little late here in Halifax, but that's okay. I had to stay up late to see the hockey game last night anyway, which was in Vancouver. So 2 nights in a row. There you go. So look, what I will have been asked to discuss is how to improve your adenoma detection rate. What I'm going to do is to review ways and means of improving one's ADR. We'll talk a little bit about why we should, although I won't go into great depth on that. I'm going to talk a bit about colonoscopy techniques, distal attachment devices, and weird lights. And that'll sort of tie in then to Michael, what Michael's going to do later on with his AI stuff. So yeah, what's the big deal with ADR? I debated whether I would show this slide. I'm getting sick of this guy, but anyway, I just figured, what the heck? What's the big deal with ADR? Well, do I really need to improve my ADR? Now, when I ask this in other talks, everybody just says no to all of these questions. In BC, at least you guys I know can answer yes to some of these. Do you measure performance? And yes, in terms of your context of your fit cases, like in Nova Scotia, we are measuring. And how do you measure compared to your mates? Well, you're finding out every year. You get a measure and you find out where you fit on that curve. Have you ever been observed since residency? Has anybody ever actually watched you do a scope? Now, again, I know you have the DOPS in BC, so most of you probably have had some observation, which I think is incredibly important. And I think is a major flaw in the way we do things in terms of medicine, particularly procedural skills. And are you aware of recent improvements in colonoscopy techniques and technology? And I guess this is sort of a key thing and some of the things that I'm going to address. So do we need to improve your ADR? I would argue yes, because I don't care who you are. I would say the person who's the top of the curve in BC can still get better. And that's the kind of point that I always make when I'm speaking to people. These are some early data from Nova Scotia. And obviously, as in BC, if you measure performance, we're not all the same. There's quite a variation. Now, these numbers are not great. These are early days. I'll show you some more recent stuff in a bit. But the point of this slide is just to show that there's a striking variation in adenoma detection rate among endoscopists. So I didn't go into the literature in depth. I'll just sort of touch on a couple of things and then go into one paper. But basically, we know, and there's lots of supportive literature for this, that the higher your ADR, the better the performance of colonoscopy. The higher your ADR, the lower your risk of having an interval cancer, of having an advanced stage interval cancer, and having a fatal interval cancer. And these are studies basically from the Polar Screening Study and Doug Corley in Kaiser Permanente in California. So should we try to improve, or are we stuck where we are? Are we like Winnie the Pooh there with the honey jar? Are we stuck what you are? You've been in practice for 10, 20 years, and that's as good as it's going to get, or can we get better? This is some work from Kaminsky, published a few years ago now, and they basically looked at, got this thing in the way here, can I move this? There we go, get that out of the way, thanks. Will improving your ADR actually have any impact on the risk of interval cancer? And what they did is, they did a similar thing to what you're doing in BC and what we're doing in Nova Scotia. They wanted to improve performance. They followed this over several years. The way they improved performance was annual report cards for their endoscopists. And you can see the numbers there, the numbers of endoscopists, 150,000 colons. You have to understand now that the Polish screening study program are average risk. This is not a fit-based program. It may be now, but in the time that this study was done, these were average risk colonoscopies, similar to what we see in the United States. 75% of endoscopists actually improved their ADR during this study. 18% there were no change, and there was a small percentage who actually got worse. And you can see the follow-up large study. And if you look what we expect to see, we've seen previous studies is exactly what we'd expect. As your ADR is better, those who are in the quintiles, the higher you are in the quintile, the lower the chance of having a cancer in terms of a missed cancer or an interval cancer, which of course is the outcome that we're trying to avoid with screening programs. And if you look at the individual endoscopists, if you looked at the results, if you were here and you didn't change, you didn't do very well, nothing really changed. But those who moved up the scale in terms of adenoma detection rate, or the high detectors who stayed in the high detection quintiles, their chances of having a missed cancer, a missed lesion were significantly better, significantly less than those who were lower ADR detectors. So there's no question that going through the exercises that we go through to find ADR is really important. Can you get better? Well, this is what we've done in Nova Scotia, and it's similar to sort of what Jen has already reported with you guys. These are unadjusted numbers. These are the mean adenoma detection rates for physicians with more than 40. These are fit positive procedures. These are not outside colonoscopy. We have the same issues that you have in BC. We know what's going on in the screening program, outside the screening programs, a dog's breakfast. No one has any idea whatsoever. But basically, you can see in the early days, we were running in the sort of the high 40s, 50% range. And through the years with C courses, better technology, and ongoing report cards, the last reported provincial average was 67%. That was in 2020. We missed last year. The most recent one that hasn't come out yet has now gone up to just below 70%. So we're continuing to increase. And this just shows across the board that all of us can get better. And it doesn't matter who you are. These are GI, surgeons, people who've been in business for a while, people who are relatively new grads. So it doesn't really matter who you are. We can all improve. How? By far, the easiest way is improve your bowel preps. Now, again, in the context of screening programs, we're paying attention to things like this, but in terms of individual practice, there's no question. Better bowel preps, particularly split dosing, you're going to find you see more. So split dosing is a must in this day and age. Take a course. Here we go. Here's one of the early courses in BC. That picture was taken. We're going to teach you things like ergonomics, how to improve the efficiency of your endoscopy, but also we'll talk about better polyp detection, various things that we would teach you in these courses. Slow down and take a look. One of the things I see most frequently when I watch people do endoscopy, particularly when they get a little stressed, is things start flying around and the tip starts going like a windshield washer and playing a Rubik's Cube with the handle of the scope and everything just goes crazy. You're going to miss things. You're going to miss these lesions here, these little sessile serrated lesions, particularly this guy here in C. That would be hard to see. And if you're not going slowly and looking carefully and looking for vascular changes and mucus patches, you're going to miss these things. So slow down. Key importance. We know the papers, they've been around for 15 or more years, showing longer withdrawal time, up to probably 8 minutes at least, maybe outside 10. You're going to increase your ADR as you go slower. Position change. I'm a big believer in dynamic position change during endoscopy. It improves the view on insertion, minimizes the distension of the colon, deangulates sharp bends, avoids loop formation, and is more comfortable for patients. There's lots of deep information suggesting this. But changing position on withdrawal also improves your adenoma detection rate. And this is a systematic review and meta-analysis published about 2 years ago in Endoscopy International Open. 6 studies looking at pooled adenoma detection rate in dynamic position change compared to no, and compared to a control group where the procedure was done in the left lateral position only with no change, 41% to 34%. There's roughly a 7% average, just increase, just in changing position on withdrawal. Second look. We've heard a lot about second look, particularly in the right colon. This is a quote I Googled. I have no idea who Matthew Williamson is or what the context is, but I thought it was perfectly apropos for what we do in colonoscopy. Take a second look. You might not have seen it all. I don't think you could express it any better, particularly in terms of the right side of the colon. Systematic review, looking at second look, second time examining the right colon in a forward view versus the second look retroflex view, comparing these both to non-second look, standard colonoscopy. And the second look in the forward view increases adenoma detection rate by 10%, in the retroflex view by 6%, and in this particular meta-analysis, sorry about that, I think I'm on a timer thing here. The difference between these methods, between looking for a second time in a forward view or doing that second look retroflex, there was no significant difference. Now, again, there's only 4 studies. They weren't huge studies, so this may be based on numbers and beta errors or whatever. But at this point in time, probably not a difference. I think one thing that I do say is I do second forward look. I don't routinely retroflex. I will, but I don't routinely do it. But what I do is when I do my second look, I don't do it in the same position. So for example, I generally tend to be in the right lateral when I'm in the cecum, because I generally get better views of the cecum in the right lateral position. So I will come back in the right lateral and then I'll go back to cecum and I'll put the patient in left lateral and do it in the left lateral position. Or if I was supine to left lateral. So I don't do the second look in the same position. Now, I don't have literature to support that. That's my practice. It makes sense to me. I seem to find things the second time, but who knows? Another water insufflation. I think Dr. Back is going to talk about water in more detail, and I wasn't sure exactly what he was covering, so I'm just going to go a little bit through this, with specifically to ADR. Water insufflation is definitely more comfortable compared to gas. Gravity enhances the benefit of position change, and it does increase adenoma detection rate. And this Kochen model just shows beautifully when you put water in, you collapse down and lower down that sigmoid colon, you deangulate, whereas when you put air in, you tend to this sigmoid rises up, and it actually makes angulations and bends worse. So it actually is counterintuitive, but water makes far more sense in terms of managing sigmoid colon. Again, another systematic review and meta-analysis of 17 studies compared water exchange to water infusion to gas insufflation. Now, water exchange has been defined as you're inserting the scope, you're flushing in the foot pedal, flushing in water, and you're suctioning at the same time. So the idea being is that I guess you're actually removing water on insertion of the colonoscope, and it's said to leave you sort of a clear layer of water in terms of the colon. You're not using air to insufflate. Compared to water infusion, where you're using water to open the scope, you're not using air. So you're using water to open the colon. You're not using air for insufflation until you get to the cecum, and you're removing water on withdrawal. So that's what water infusion has been defined as. And then, of course, gas is gas. Water exchange, in terms of this systematic review published 4 years ago, was superior to the other modalities, reported as odds ratios, but you can see the numbers here. Water, in terms of looking at proximal lesions, proximal adenoma detection rates, similar, another meta-analysis, same kind of result. Water exchange was again superior to the other modalities. So in summary, water exchange appears to be superior to water infusion or air insufflation, gas insufflation. It is, however, said to be slower. It can add 3 to 5 minutes to a procedure. And how does the use of water impact your results if you're using position change and looking slowly and doing second look? I have no idea. In my practice, I do all of the above. I really think I'm a strong advocate of this, but I cannot say to you how much one will add to another. And this is a view in Indian Harbor, Nova Scotia, the South Shore, one of my bike rides. This is where nice stop on my bike ride. So if you ever get out here, come and see the South Shore. Gadgets. Let's go on to gadgets. Network meta-analysis done 4 years ago, looking at adenoma detection rates using the CAP, endocuff, and endoring devices, 25 randomized controlled trials. Basically, looking at this paper, the benefits of one device versus another was really not clear. The conclusion was from this paper that there was a modest increase in adenoma detection rate using a gadget compared to a standard colonoscopy with no distal attachment device. And interestingly, I don't quite understand how they came up with this reading this paper, but bottom line, they seem to come to a conclusion that low performing endoscopists, in terms of low adenoma detectors, putting a gadget on the end of the scope didn't make you a whole lot better. In fact, the people who seemed to do better were people who were already doing well. Be that as it may, I can't really expand on that, but that was one of the conclusions of this paper. I will tip my hat to the guys in Calgary. I mean, many of you are probably aware of the paper just published by Nazir Forbes and Steve Heitman's group last year. This was an observational study from the Forzani and their screening program, where they did a 6-month period where they just did their standard scopes and they measured their adenoma detection. And then they did a 6-month period where they were using endocuff vision, which is the second generation. The meta-analysis I showed you earlier was the first generation endocuff. So maybe this device works better. I've not seen a comparative head-to-head, but talking to Nazir, that's what he thinks is the case. In the second 6-month period where people were encouraged, they weren't forced to, but they were encouraged to use the ECV, about 3/4 of the time it was used. It did not, use of the endocuff did not have any impact on time of procedure, cecal intubation, patient comfort, sedation use. The ADRs they found was 46% in standard and 54%, so about a 7 to 8% increase using this device. The issues, though, with these devices are, what's the cost effectiveness? We don't really know at this point whether you can justify the cost or not. And what are the benefits of other techniques? In other words, if you're using this device in addition to water and position change and so forth, how much does this add? and it's hard to know, and I don't think we really know at this point in time. Finish off quickly with image enhancements. All of the endoscopic manufacturers have these various techniques and devices, and they're coming up with new things all the time. Essentially, I don't have the reference, but the meta-analysis that I've seen looked at really have not shown anything that's consistently superior to white light endoscopy. I've seen a couple of papers recently suggesting that narrowband imaging, for example, might be better. I kind of think it's a bit of a moot point anyway, because I think AI that Michael's going to talk about in a bit probably is going to put this to rest anyway. I'll be interested what his thoughts and comments are on that. So I won't really delve any more into that. And again, it's not a big practice of mine to use I use narrowband imaging for polyp assessment. When I found the polyp and I want to assess it, have a look at the mucosal detail, I'll use narrowband imaging and the magnification, but I don't use it routinely coming out to help me. At least not. I'll be interested in the other panelists, but that's my experience. So in summary, it is definitely possible to increase your ADR. Changes in colonoscopy technique make this possible. Position change on withdrawal, water exchange, a second look down the right side in a different position, and slowing down. It's not clear yet which combination, if any, is the most effective. Gadgets may be useful. We just don't know the cost effectiveness yet. So we'll be interested in where this goes with that. And thank you. And there's the view of Mahone Bay from our little place down the South Shore. So thank you very much.
That was fantastic. Thanks so much, Don. So our next speaker of the evening is Dr. Adrian Bach, who is a gastroenterologist in Kelowna General Hospital. He's a clinical assistant professor of medicine at UBC and has had a number of administrative roles, most recently for British Columbia as co-chair of the Gastrointestinal Endoscopy Access Committee for the Ministry of Health, and puts on great clinical care in Kelowna, is also a clinical researcher, and has been a strong advocate for colonoscopy quality in the colon screening program. So thanks so much, Adrian, for agreeing to give this talk.
Thanks, Jennifer. I would just like to begin by respectfully acknowledging that I am joining the meeting today from the traditional, ancestral, and unceded territory of the Syilx Okanagan peoples. It's a privilege to live, work, and practice medicine on this land. So everyone understands the adenoma to carcinoma sequence and the intent of colon screening. If we find the lesion early, we can remove it, reducing the subsequent incidence of and mortality associated with colorectal cancer. Guaiac-based fecal occult blood testing and flexible sigmoidoscopy have demonstrated both in randomized controlled trials in patients at average risk for colon cancer. Nearly 3 decades of research on the effect of screening average risk patients for colorectal cancer with flexible sigmoidoscopy has been completed with the long-term follow-up from the last of 4 randomized controlled trials being recently reported. The SCORE trial from Italy was the last to report long-term results in November in JAMA. Despite differences in study design between the 4 trials, they also showed similar benefits, which was an 18 to 26% reduction in colorectal cancer incidence, which translates into 6 to 8 patients per 1,000 screened, with a 21 to 30% reduction in colorectal cancer mortality, translating into 3 to 5 patients per 1,000 screened, with results now lasting up to 15 to 20 years. Even though patients with pathologic findings at flexible sigmoidoscopy were referred for full colonoscopy with subsequent surveillance, screening had little effect on colorectal cancer incidence or mortality in the right colon proximal to the splenic flexure. Importantly, the SCORE trial showed a lack of mortality benefit in women, similar to a reduced benefit of screening in women in the US and Norwegian FlexSig trials. With respect to the recommended screening intervals for flexible sigmoidoscopy, which is currently recommended at 5 years by the US Preventative Task Force and 10 years from the Canadian Task Force for Preventative Health, This research suggests that we could extend this interval up to 15 years, which would reduce the cost and burden of screening to patients and on resources. This slide is actually taken from the UK FLEX-SIG study showing results after 16 years of long-term follow-up looking at colorectal cancer incidence and mortality. You can see that although incidence and mortality are reduced, there is no effect in the right colon. If you look at the top right-hand of the slide, you can see that the control group, screening group, and not screening group all overlap and there's no separation. The SCORE trial reported the same, but did not include a similar graphic. The SCORE investigators went as far as to add the descending colon into their calculation for effect in the right colon, and it still did not provide a significant reduction in colorectal cancer incidence or mortality. It's important to understand that meta-analyses of observational trials of colonoscopy also fails to show a benefit of screening in the proximal colon. The lack of benefit of colonoscopy in the right colon has prompted interest in research into quality of colonoscopy within screening programs, and that's why we're here tonight. It's often said that the best screening test is the one the patient completes. So failure to complete a screening test after an offer or failure to follow through with a colonoscopy after a positive FIT or flexible sigmoidoscopy could contribute to the lack of effect in the right colon and explain the moderate effect of screening in the distal colon. We also have literature that suggests that a delay to colonoscopy beyond 6 to 9 months after a positive FIT test also negates any benefit of colonoscopy in terms of subsequent incidence or mortality. Failure to reach the cecum would definitely contribute to the lack of benefit of screening in the right colon, and our quality thresholds for the BC colon screening program have been set at 95%. Our unit recently reviewed our bowel prep scoring system to attempt to standardize on the Boston Bowel Prep score. We know that a score of 6 on 9 with each segment scoring at least 2 is defined as adequate. Anything less requires adjustment to subsequent screening or surveillance recommendations. FIT positive patients with inadequate prep should have a repeat within a year, within 8 weeks if an advanced adenoma is seen. Adenoma detection rates attempt to estimate procedural performance, which of course is affected by cecal intubation rate and bowel prep adequacy, but also dependent upon other factors such as withdrawal time and potentially other factors. ADR minimum thresholds for colon screening have been set at 25% in men and 15% in women, 20% overall, assuming a 50-50 screening mix. These were the original American guidelines, and I think they've been updated to 25%, so that's 30% in men, 30% in men and 20% in women. It's important to recognize that these are thresholds for screening colonoscopy in average risk patients. Adenoma detection rates can be gamed, the so-called one and done mechanism. So perhaps adenomas per colonoscopy or APC should become the primary quality measure when considering traditional adenomas. It has been estimated that for every 1% increase in your ADR, there's a 3% reduction in colorectal cancer incidence and a 5% reduction in colorectal cancer mortality. With respect to polypectomy, poor technique or piecemeal resection can influence rates of recurrence and contribute to poor performance of colonoscopy screening. But maybe there's more to the story. Despite our efforts to increase patient participation in screening, focus on quality, and improve patient recall and surveillance, interval cancers still occur. So in the 30 years it's taken to complete the long-term follow-up in the FLEX-SIG trials, we have now recognized an alternate pathway to colorectal cancer, the so-called serrated neoplastic pathway. The failure to recognize this pathway may also explain our inability to make an impact with screening in the right colon. In this pathway, hypermethylation in the promoter regions of tumor suppressor genes can lead to other gene mutations, which then lead to dysplasia. These lesions can be dormant for years, but once they become dysplastic, quickly transform to cancer perhaps explaining their predominance in histologically confirmed interval cancer. Michael Ma and Michael Burke in Australia published a review in 2017, which discusses the serrated neoplastic pathway with strategies to detect and resect, along with implications for surveillance. Sessile serrated adenomas or polyps were once considered to have no malignant potential. I can remember as a fellow reaching the cecum and seeing a large hyperplastic lesion with inherent mucus, and we left it there, believing that was the thought. Sessile serrated adenomas or polyps are the primary premalignant lesion in this pathway, found mainly in the right colon. Traditional serrated adenomas occur less frequently, often are pedunculated and are located primarily in the distal colon. These lesions can be difficult to detect with subtle, indistinct borders, often recognized due to the inherent mucosal cap. Their presence is associated with synchronous or metachronous advanced neoplasia. There is a higher risk of incomplete resection, as the border for resection can be difficult to identify. Bottom line is that failure to detect these lesions will affect your subsequent surveillance and success of colon screening. It's now recognized that 30% of all colorectal cancer arises in this pathway. As mentioned, once dysplasia develops, there's a quicker progression to cancer than in the traditional adenoma to carcinoma pathway, even in small lesions. Studies indicate that 30% of serrated pathology over 20 millimeters in size harbors dysplasia. As more is learned, surveillance recommendations change, but are dependent upon a size greater than 2 centimeters, the number of lesions over 1 centimeter in size, 2 or greater, whether or not there's the presence of dysplasia, along with the type and adequacy of resection. They require unique surveillance recommendations, and I would argue we should probably be more aggressive in follow-up of this pathology. This is just a boring slide of 3 examples of serrated pathology, just to give you a bit of a break. So what is the cancer risk? Our understanding of the risk associated with the serrated neoplastic pathway is rapidly evolving. This study out of Utah, just published in the Red Journal, attempts to define the risk. The World Health Organization defines serrated polyposis syndrome as having 5 or greater serrated adenomas or polyps being greater than 5 millimeters in size, with 2 greater than 10 millimeters in size proximal to the rectum, or 20 lesions of any size throughout the colon with 5 proximal to the rectum. These are lifetime calculations, meaning findings at subsequent colonoscopy are additive. If you have serrated polyposis syndrome, you have a 10-fold increased risk of developing colorectal cancer compared to controls with normal screening colonoscopies. First-degree relatives also have a 5-fold increased risk of colorectal cancer. Surveillance recommendations are to repeat colonoscopy yearly in patients with serrated polyposis syndrome and initiate screening in first-degree relatives at age 40 or 5 years earlier than the earliest colorectal cancer, whichever is younger. With respect to sporadic serrated lesions, all relatives, whether first, second, or third degree, appear to be at increased risk for colorectal cancer. However, it only appears to be present when there's a traditional adenoma also identified. Patients with greater than 3 serrated lesions, a serrated lesion 1 centimeter or larger, or a serrated lesion harboring dysplasia requires closer surveillance. First-degree relatives of patients with a serrated lesion 1 centimeter or larger, or with a serrated lesion with dysplasia, should initiate screening at age 40, similar to patients with a family history of colorectal cancer or advanced adenomas. So how significant are these lesions, and what is the prevalence? How many should I be detecting? Is adenoma detection rate enough, or should I be tracking my serrated lesion detection rate? This study from Taiwan in 2017 looked at an average risk screening population of over 6,000 patients without symptoms. All these patients had concurrent FIT and colonoscopy screening. In this study, the prevalence of serrated adenomas and polyps was 1.4%. This should be interpreted alongside the adenomas and advanced adenomas detected. And remember, this is an average risk screening population. If we accept an adenoma quality threshold or adenoma detection rate quality threshold of 20% in average risk patients, we should expect at least a prevalence of 1.4% in our colon screening program. The overall ADR in this study was 27%, by combining serrated pathology with traditional adenomas with the ranges listed. As with other studies, FIT is not sensitive in detecting serrated pathology, irregardless of the size of the lesion. This study from Austria gives us further information regarding the prevalence of serrated pathology in an average risk screening population. In this case, where greater than 50% of the patients were women. In Austria, everyone is offered colonoscopy screening as part of a national colorectal cancer screening and quality assurance program. I have to mention that there were some patients as young as 30 included in this trial. I guess in Austria, just fear of having colonoscopy is an indication to proceed fear of having colon cancer is an indication to proceed to screening colonoscopy. What the study attempted to demonstrate was that if your colonoscopist had a adenoma detection rate greater than 25%, you would be protected. Subsequently, without getting into too many details of the study and whether they proved it or not, I just wanted to point out that although this was reported in late 2021, they completely excluded serrated pathology from their analysis. If you looked at the numbers, you can calculate a serrated lesion detection rate just about 2%. So again, an ADR 22%. The study really didn't tell us exactly what location these serrated pathology was located, nor did it tell us the gender. So perhaps the preliminary results from the Nordic trial give us the best estimate of serrated pathology. This is one of 3 ongoing randomized controlled trials looking at colonoscopy as primary screening in patients at average risk for colorectal cancer. And of the 94,000 patients enrolled, 40% of the patients were randomized to complete colonoscopy, with about a third of those who were randomized actually going on and completing colonoscopy. So that's 12,500. They reported quality endpoints relevant to our expected level of practice, with cecal intubation rates of 97%, withdrawal times of 10 minutes, and Boston Bell Prep scores of 8. Unlike the 2 previous studies that I mentioned, possibly as a result of greater insight and expert pathology, these results demonstrate a significantly higher rate of detection of serrated pathology. The proximal serrated lesion detection rate has been suggested as a surrogate quality indicator for rates of interval cancer. Time will tell whether a proximal ADR of 8.6 is enough to extend the mortality benefit of colorectal screening to the proximal colon. In this study, the adenoma detection rate was 30%, with 28% of endoscopists falling below their quality target of 25% overall. So to improve our outcomes in colorectal cancer screening, perhaps we need a better mousetrap. So this summer I was up early. I was, of course, on my computer. I was drinking my coffee, and I turned to the right just to see a mouse scurry across the floor. I was a little stressed. First of all, thinking there'd be more than one of these in my house. But the other thing that was stressing me out was the thought of having to set the trap, because I'm the guy that fires his finger in the trap a few times before I get it set. And then the mouse usually comes by, picks the piece of cheese off, doesn't trigger the trap. And, I don't get rid of the mouse. Somebody suggested to me that they improved the design. It makes it easier to set. And it was suggested to me that I should just put a little bit of peanut butter in there instead of cheese. So the mouse has to work at it to get rid of, or to take the peanut butter out of there. Suffice to say, I was thankful that my problem was eliminated overnight, which brings me to water exchange. The technique has been well described. This is a paper or reference from Dr. Cadoni in Italy and Dr. Ishak in the UK, which describes the technique with a link to an excellent online video. And just to summarize briefly the differences between water exchange and what other water-aided techniques. With water exchange, the carbon dioxide or air, if you're still using room air, is turned off during insertion. There's a focus on aspiration of all water and air on insertion so that the net amount of water infused by the time you reach the cecum is as close to zero or negative if possible. This allows one to float through the colon while navigating with your torque sphere. It facilitates colonoscopy with minimal turning and pressure required to reach the cecum. A Delphi review of water-assisted colonoscopy techniques has been published, summarizing consensus opinion regarding advantages compared to conventional colonoscopy with gas insufflation. With respect to water exchange specifically, it enhances cecal intubation rate. It results in the highest Boston bowel prep scores and is associated with the highest adenoma detection rate. Using water exchange also results in the lowest pain scores, often facilitating colonoscopy without sedation. There was also consensus that underwater resection, either with underwater polypectomy or underwater EMR, was safe, but it also increases R0 and unblock resections of lesions between 10 to 20 millimeters in size. A recent study out of Germany suggested similar benefits for larger lesions between 20 and 40 millimeters in size. The cost of all these improvements, as Don has alluded to, is an increase in total procedure time of 2 minutes when compared to conventional colonoscopy. A meta-analysis of 17 randomized controlled trials suggests that water exchange increases ADR. Water exchange was found to have the highest adenoma detection rate, being 41% when compared to water immersion, 34%, air insufflation, 30%, and CO2 insufflation, 31%. It also was found to have the highest right-sided adenoma detection rate, which is important if you want to limit your interval cancer rate. As mentioned in the Delphi review, Boston bowel prep scores improve, as do pain scores. But again, at the cost of 3 to 5 extra minutes of insertion time, which the Delphi review suggests you gain back on withdrawal. So while an enhanced adenoma detection rate is associated with a reduction in interval cancer rates, it has been suggested that serrated lesion detection rate might better correlate with interval cancer rates, given that colorectal cancer arising through the serrated neoplastic pathway is the predominant pathology in interval cancer. This study examines both adenoma detection rate and serrated lesion detection rate in patients at average risk for colorectal cancer, screened with either chromoendoscopy with water exchange, or air insufflation colonoscopy. Since this study was performed in the VA system in the United States, one has to interpret it knowing that greater than 80% of the patients were men. Although previous studies suggested that water exchange was superior to air insufflation with respect to adenoma detection rate, the ethics reviewers for this trial insisted on the inclusion of an air insufflation arm of patients. This is a great example of why randomized controlled trials are needed and why you cannot simply compare adenoma detection rates to historical controls. It's important because in this study, the primary endpoints of adenoma detection rates overall and proximal adenoma detection rates were similar amongst all techniques. Serrated lesion detection rate, however, was highest in both water exchange groups without any statistical difference between them. In this study, water exchange demonstrated procedural advantages, improved Boston bowel prep scores with similar cecal intubation rates and procedure times. This slide summarizes the results. It's important to understand that by proximal here in proximal colon, they define proximal to the splenic flexure. They include hyperplastic polyps of any size in the calculation of serrated pathology. Proximal hyperplastic polyps more closely resemble serrated pathology, carrying more risk than distal hyperplastic polyps. You would expect this serrated lesion detection rate would actually be even higher if you use the updated World Health Organization definition in 2019 for serrated lesions proximal to the rectum, also carrying risk. Remember, this adenoma detection rate of 60 to 62% has to be interpreted knowing that 80% of these patients were men, but they were all at average risk without symptoms and without previous fecal occult blood testing. So if you take this study and you do a deeper dive, I included this slide which shows the adenoma detection rate of a single expert endoscopist over time. Again, Joseph Leung was the investigator. He's been doing this research for the last 15 years. And he's a master endoscopist, twice named by the ASG and the ACG. Earlier studies here show that water exchange had an advantage over air insufflation with respect to ADRs. The study in 2012 suggested that chromoendoscopy with water exchange was superior to water exchange with respect to ADR. The current study, however, shows that adenoma detection rates were the same through all of it. This led the authors to conclude that if you're a colonoscopist with a high adenoma detection rate using air insufflation, you're not likely to improve your adenoma detection rate by adding in water exchange colonoscopy. I'd have to interpret it slightly differently in that I would expect that after 15 years of doing water exchange colonoscopy, your air insufflation colonoscopy is as close to water exchange, only you leave the CO2 on during insertion. Irregardless, this slide suggests that there's a learning curve when it comes to adenoma detection rate when one's focused on adenoma detection rate. And time's going to tell whether or not the same will be true with respect to serrated lesion detection rate as we study and examine this quality endpoint. So what are some of the possible explanations for an enhanced adenoma detection rate or serrated lesion detection rate? Well, I'd have to say probably the number one would be the conversion of the Boston bowel prep score to a higher score with effective water exchange on insertion. We can detect polyps underwater on insertion. Pedunculated polyps just fall into the lumen of the colon. Flat Paris 2B lesions become elevated or 2A lesions underwater. Water exchange allows loop reduction so that when you reach the cecum, you have a shorter scope inserted, so the withdrawal phase of your colonoscopy is more controlled. Some authors talk about less cleaning distractions on withdrawal, so you're spending more time looking for polyps than you are cleaning away what's left. And other authors have suggested that there's a natural underwater magnification to account for your increased adenoma and serrated lesion detection rate. So to summarize, water exchange probably enhances adenoma detection rate in low detectors, but it's not likely in high detectors. If your adenoma detection rate's greater than 60% in an average risk population, you're probably good. However, kind of frozen here. Hold on a second. Water exchange doubles your proximal serrated lesion detection rate, even in high detectors. I would have to suspect that proximal serrated lesion detection rate will be a better surrogate for your risk of adenoma cancer. Practicing water exchange improves your overall colonoscopy technique. So again, you're getting closer to water exchange only with CO2 left on. Now with water exchange, unlike other technologies, there's almost no cost. There's a low barrier to implementation. You do need a water pump, and I can remember early in practice 20 years ago that we didn't have every room with a water pump, and it's amazing to think now how far we've come. And some suggestions or requests from the colon screening program, and I'm delighted to see that Jennifer's covered most of these things. It would be nice to know what our proximal adenoma detection rate is in addition to our overall adenoma detection rate. It'd be nice to know a gender-specific adenoma detection rate when we get our report cards. It's really nice to see that we are going to get a serrated lesion detection rate, and we probably don't really understand what it means yet, but it will be important going forward. It would be nice to know the breakdown of those patients that we are doing, and I guess Jennifer has reassured us that our adenoma detection rate is calculated strictly on adenomas and strictly on patients who are colonoscopy after a positive fit, and they don't include surveillance and other high-risk patients, which is important when you're interpreting the results. And as well, she beat me to the punch, 25% adenoma detection rate in a fit positive screening population is not adequate. Joseph Liang and other people talk about an aspirational adenoma detection rate in fit positive males at 75%, which is in line with the recommendations which Jennifer has put forward. So we should probably be aiming for an adenoma detection rate, a pure adenoma detection rate, not one that includes serrated lesions at greater than 60%, but then we should also aim for a serrated lesion detection rate higher than the 9% that we've gotten, or the 9% or 8% in the Nordic trial, somewhere probably north of 20%. And if you're including proximal to the rectum as serrated pathology, it's probably going to be more like 30 or higher. So with that, I'll yield back to Jennifer. Thank you.
Great. Thank you, Adrian. That was a really interesting talk. I have several questions for our panel discussion for you. So our last speaker of the evening is Dr. Michael Byrne, who is a clinical professor of medicine at UBC and works as a gastroenterologist out of Vancouver General Hospital and UBC Hospital. And he has been a speaker internationally on this topic, and we're really lucky to have him here tonight. And I've heard him speak before. He's excellent. I'm really excited to hear about the future of AI helping us improve our ADR.
Thank you, Jen. As a line I've used before, but clearly you actually did it. You read my mother's bio. It's great. Okay, let me just share screen. All right. Give me the thumbs up, Jen. All good? Okay. So thank you for the invitation. Hopefully I can add a little bit more to the great detail that we heard from Don and Adrian as to how we can basically improve our colonoscopy technique and decrease colon cancer, because that's what this is all about. So I'm going to bring you through some of the current AI solutions, some of the promise, some of the pitfalls, and some of the allied aspects of how technology can help us here in colonoscopy, and in particular in ADR. These are my disclosures. So hopefully at the end of this session, you'll have an appreciation of where we're at right now, 2022, for AI applications in GI, and in particular for CAD or colon polyp detection. Understand that these are not perfect tools by any means at this point. So what are the challenges and limitations? How can we implement them into our practice? We're going to talk about real world use and real world issues, like how do these techniques get reimbursed? And then a snapshot into the future as to where we're going. I don't think it's an overstatement. I have a significant bias, clearly, but to state that we are undergoing an AI revolution in healthcare. It really is more than touching every single field that we're in, from drug discovery to every clinical specialty, from radiology, dermatology to GI and GI endoscopy. And AI is a very umbrella term. I think it's impossible now to pick up a medical journal or a lay article and not read something about AI. So many people are very familiar with the term now, but it's an overarching term that includes subfields such as machine learning, which is basically teaching a machine to do what the human is intuitively doing. And another subset of that is deep learning, or these neural networks of interconnected layers. That's the real bread and butter now of most computer vision algorithms. Again, you're using AI pretty much every time you pick up your cell phone, so it's not exactly foreign to any of us anymore. And we really are just here. We're just at the intersection where AI has started to match human performance. In some areas, maybe exceed, but certainly lagging behind still in many aspects. But I really believe we're heading to the right side of this diagram in the not too distant future. So we need to work out how to be human and machine in perfect harmony. These are the neural networks. Obviously, this is the neural network, the human neural network upon which the contemporary computer neural networks are based. And here is a schematic that applies to colon polyps. Hopefully, you can see on the left there, we're training these models with lots of input images from videos of normal colon and colon polyps. And then those data points are fed through multiple layers, often hundreds of layers deep, of these neural networks. There's lots of forward and back propagation all along. And finally, in this case, you spit out a binary output as to the presence or absence of, in this case, a polyp. So that's the basics of how they work. If anybody out there listening today still thinks they don't need AI, or AI is hocus pocus and you don't need it in your practice, I'll use an extreme example here of imaging, which I think most of us, maybe not all, but most of us here today don't know how to interpret this technology, which is volumetric laser endomicroscopy, optical coherence tomography in the esophagus. I have no idea what I'm looking at in this. It looks like a seismograph earthquake prediction to me. And to most GI doctors, it looks like in 1970s TV. But there was a study published 3 or 4 years ago that showed that it took 2 world experts in this field a couple of hours to get an accurate classification of a VLE read, and a machine did it in about 90 milliseconds, so 40,000 times quicker. So there are some things where you can actually just hopefully appreciate there's no point in even trying to compete. So what about back to polyp detection, which is what I was asked to speak about today? Well, the cat is already out of the bag. There are already several commercially available solutions from all the major vendors: Pentax, Fuji, Olympus, Medtronic. In Canada, many or most of you will be familiar with the GI Genius CAD from Medtronic. It's the first Health Canada approved detection solution for polyps. But as you can see, all the vendors are now in this space. Here is actually now an old video from Cesare Hassan in now in Milan with the GI Genius, or the caddy from Medtronic. I'll just quickly show this in case any of you haven't seen it. So pretty straightforward user interface here, bounding box in green, showing you in the middle of the screen, there is a polyp. You might say that's pretty obvious, but the idea is, as Adrian and Don have been reminding us, we just need to get better from where we are. And anything that increases our pickup is to be encouraged. 20 years ago, people were, or longer, people were trying to bring technology, computer vision to this field. This was the beginning of the more contemporary AI that I just showed you in that video. These were all hand-labeled, incredibly laborious hand labeling of single still images, no video flow here. The algorithms and the processes were not quick enough to do live endoscopy. And this was only able to tell you if there was a polyp somewhere in the screen, not whereabouts on the screen was the polyp. But again, this was the work that got things going. And we've gotten a lot better overall in computer vision in the last several years for object detection. So now contemporary algorithms can tell you not only can they classify, tell you there's a polyp there, or localize, tell you there's a polyp there and where it is, or true object detection where it's showing you, for example, in the third diagram across there, there's a diverticulum and a neighboring polyp, or for more field defects like Crohn's, colitis, Barrett's, esophagus, it can actually give you what's called instance segmentation, where it's able to classify every single pixel in that image. Very important for field defects and these more amorphous polyps that we also deal with now. The algorithms involved here are incredibly data hungry, incredibly. Data is outrageously valuable now in this space. It's a big fight and a big race to procure data. One 15-minute video that you may take of your own procedures contains close to 30,000 images at 30 frames a second. So if you can imagine trying to hand label all of those frames and then do it for 1,000 videos, you're really talking in the millions and millions of frames, and it's outrageously laborious. Thankfully, in the last few years, there have been much better ways to amplify the human gold labels or gold standards. So you can have experts or less than experts label frames that represent polyps. And then there are many different techniques now in machine learning to amplify and semi-automate or automate the labeling of most of the rest of the frames. Here in this particular model, the doctors involved only had to label around 2% of the frames, and the rest of them were labeled in a matter of minutes. So thankfully, data labeling has become less of an issue in the last couple of years. So what about the evidence for the various caddies that you've seen there and the papers that you've read? Well, it's still a bit of a hodgepodge, unfortunately, as it is often the case in many new fields. There's been little attempt until recently to have a kind of consensus as to how to run these studies. Thankfully, that's changing now. It's some new guidelines such as the Spirit AI or the Consort AI guidelines, which are trying to encourage us to do these in a standardized fashion. But here's a meta-analysis of 6 studies up till 2020. And you can see that overall, look at the risk ratio there on the far right, these tools do seem to improve detection. They are somewhat disparate in their makeup. This shows you that there's a whole range of flat polyp makeup in the training data sets or the testing, training, and also when it comes to things like lateral spreading tumors. So this is a somewhat heterogeneous population that's been looked at through these various studies. And that's a weakness. So we need to move beyond that. Again, I'm going to show you the current evidence. These are some of the top 5 of some of the commercially available models, 4 of them for detection. And you can see they're pretty good. They're very sensitive. False positive specificity rate is also not too bad. And overall standalone performance without human input is around 93% accuracy. These are the current regulatory approved CAD-E devices. In North America, I believe I'm correct in saying that it's still only the GI Genius one that's been approved, but that's going to change quickly. So let's go back to, you know, can we actually use these clinically today? Well, the answer is people are. In Vancouver here, I'm not sure if anybody from Lionsgate is on, they probably are, but I know that the guys at Lionsgate have used some hard-earned dollars to get a CAD-E solution. But you do need to question the efficacy, the effectiveness, and the value. So can it work in ideal circumstances? What's its standalone performance? That's pretty clear. Many studies show now that you definitely pick up extra polyps with a CAD-E. So standalone performance is not too bad. I think that's a fairly robust story. Do these models work in the real world? That's where we need proper controlled trials, which I'll go into, because effectiveness hasn't yet been definitively proven from efficacy of standalone performance. And then if it really does make a difference in the real world, what's the value? What are the real life studies? What are the cost implications to having this kind of GI innovation technique? Is AI as good as the human ground truth? Does it pick up what the expert picks up? So we have to consider as well the testing. So if you've trained a model, the way AI works in general, if you train a model with a fairly narrow range of data from 1 or 2 institutions with 1 or 2 experts from a homogeneous population, you'll probably get very good results. You'll get what we call overfitting, and it won't generalize outside of that setting. And that's very important to consider. So when you're testing, are you testing on the same kind of population as for the training? Or is it a more community-based, generalized, different population community, which is really what you want? What's the benchmarking against the AI? Is it a community or a non-expert endoscopist as opposed to an expert? And is the machine algorithm working on video or just the still images? These are all things you should consider when you're reading papers. You need to look and see that there's little or no selection bias. So it's consecutive cases rather than cherry picking. That there's little or no operator bias. So you want multiple people involved in the training and validation of these algorithms rather than just one or a few. And I mentioned briefly overfitting. If you have a very narrow training set and a validation set, you can really get into issues where basically the algorithm learns the patterns in the training data set, and then it does not generalize at all when you bring it into day-to-day practice. So does AI CAD-E truly improve polyp detection? Yes, but some studies suggesting it's the smaller polyps and maybe the non-adenomatous polyps. There has been some work suggesting that it's picking up more polyps, but they're often the little boring hyperplastic things that are probably not that important anyway. That is to be clarified, I think, with more studies. Overall, if you look at the 6 currently done RCTs in this space, the ADR does go up 25 to 37%. So for what it's worth, that's a significant improvement. I'm sure people like Jen running the provincial programs would be delighted if she could get people's ADR up by 12% by a change in practice or a change in technique or adapting or rather adopting technology. This is from Ali Rapici's group in Milan, published in Gastro last year, or actually the year before, looking at 700 patients, looking at CAD-E versus standard endoscopic evaluation. And you can see at the bottom there, the adenoma per colon was 1.07 with CAD-E and 0.7 without the CAD-E. So, you know, it does seem to work. That's the same thing. What about, so we do, again, if you use these models, we have to think about the clinical benefit. If the machine says, there's something there and the physician doesn't see it, who's right? Is the physician just missing the very flat polyp? If the machine says there's no polyp there and the physician sees something, who's right? Of course, for now, for sure, we are having human override, and it's human in the loop, doctor in the loop to make that decision. What about implications for resources, cost, etc.? So this is some micro simulation modeling from Yuichi Mori and colleagues, looking at 10-year screening interval here from 50 to 80 in the US, with and without CAD-E or AI, based on those previous numbers that we looked at. And you can see that they suggest that if you use AI, that in 10 years' time, we're going to have a 5% decrease overall in the colorectal cancer incidence versus no screening. So that's not to be sniffed at. We look at cost implications. It seems to be pretty cost neutral. So you'll save lives, you'll decrease cancer rate, and it's not really much more. In fact, it might even be a little bit cheaper. But of course, we need real world data. That's just modeling. We need to see over 10 years, starting now, in 10 years' time, using AI models, are we really going to have a decrease in colon cancer incidence? I think the answer is yes, and I hope I'm proven right. Cost effectiveness overall then. So of course, one argument that I've heard people kind of complain, say, well, it's picking up all these useless, pointless, small little polyps, and that's more polypectomy and more pathology evaluations. Well, that's true. But of course, any increase in CAD-E decreases cancer. That's plain and simple. And given that we've got CAD-X or optical biopsy tools coming very, very quickly down the pipe, which will hopefully allow us to discard many of those polyps without sending them to the lab. If you combine those two together, maybe your costs are neutral or actually cost saving. So don't use AI without kind of evaluating, the training and the testing of that system, because they're not all the same. Randomized control trials are definitely important here and critical to these kind of models. And we have to consider the value, the cost implications, who's going to pay for it, and potential issues like de-skilling of the endoscopist. You've had Don telling us all the C training advantages and how we can all become better endoscopists. And some people argue that AI models are going to make us all lazy again. So future questions: how does the quality of the endoscopist affect the performance of AI? How does AI affect the technical performance of endoscopists? And we've got to think about it. What are the implications in the real world? I think it was Don mentioned about slowing down. Hope this video doesn't crash. It crashed the last time I showed it. This is work from 3 or 4 years ago from Honggang Yu in China and his group, looking at speed of withdrawal using AI. So you'll see here, you're going really quickly. This is a less than 5-minute withdrawal. You're in the red zone. So slow down. This is borderline between the red and the green zone. You want to be over here, where you really are taking your time, looking behind the folds, looking at as much surface area as you can. So that's an AI tool to be something in the corner saying, hey, you're going too quickly, go back. What else can AI tell us in relation to polyps? Well, if we're taking off some of the larger polyps, there's increasing evidence now that it can also help us make decisions about risk of bleeding after polypectomy. That it can help us with sizing, because I don't care what anybody says, we are abysmal at sizing polyps, and I think that even applies to so-called experts. We eyeball it. We use an open forceps. We use the snare, but we still get it wrong. So there are techniques now that are coming that will tell us, hopefully in live time, what size of polyp we're dealing with. What about surface area? We know that we don't see all of the colon. We know we miss bits. That's quite a lot, probably. This is from Google Health, the C2D2 algorithm, showing in blue and red, blue being the, I think blue is the bits that we see and red's the bits we don't see. So you can see that we can miss, and we probably do miss quite a lot of the colon. So tools that will show that to us can also help with quality assurance. These things need to work in our daily workflow. Otherwise, they're going to be an encumbrance rather than a benefit. So what is it? Is it 2 screens? This to me is quite distracting. So is this the way it's going? Is it a picture in picture? Is it an audible beep in your ear? There's already enough distraction in the endoscopy room, certainly at VGH anyway. I'm not sure about having 17 screens. So I think this needs to be still fine-tuned. It's way beyond polyps. I won't go into any of this in too much detail at all today, but it's, this is going to apply to every field that we as endoscopists perform in: Barrett's, early gastric cancer, endoscopic surgery, pancreatic cysts, CADX for polyps, IBD, shameless plug. This is CADX in operation. There's a small adenoma, live interpretation. This is coming. This kind of work is coming soon. Here's some work from Helmut Messmann's group in Germany, looking at ESD for I think this is in the colon, pointing out vessels. ESD experts listening might say, yeah, no big deal, I can see that, but this is where it's going. Live guides to what we're doing endoscopically as we get more and more adventurous and invasive. Barrett's, the field defect I was showing you before. So just think about the field. This is pretty obvious maybe to many of us, that there's a funky looking area there in that Barrett's, which on the top left, you'll see the red area representing biopsy proven invasive cancer in the segmentation model. So maybe you say, oh, I would see that. So go forward to this one. And there's a tiny little sliver there that I'm sure many people would miss. And that actually was also found to be biopsy proven cancer. And you can see that the model on the top left there in red is showing you, saying, hey, I think there's cancer there. I'm finishing up here, but AI is going to help us not just with the live endoscopy. It's going to help us with the stuff that I'm sure most of us really don't like doing or find a pain, which is all the paperwork, all the reporting, all the documentation, report generation. There is absolutely a better way to do it. And there's no doubt that a combination of the kind of imaging AI and natural language processing, basically machines listening to us and making sense of what we're saying and putting it down in documentation, will transform how we report colons and how we help people like Jen run programs, whether you're looking at quality of performance. So in the not too distant future, we should be able to say in a room, hey, please pull my ADR trend for the last 6 months, so that we're not discouraged when we're a year behind in getting our performance. Same with making a report. Okay, so there's no doubt whatsoever in my mind that AI techniques will help us drive automated reporting, so that you sit down at the end and you just validate what's being put together. Polyps here, there, and everywhere. This type of visual pathology in this location, this size. You saw X amount of the colon. The bowel prep was Boston, whatever. Thanks very much. Press click. So I agree with Einstein, except it's not an excuse for people when I might suggest that their knowledge base is not great, and they say, well, imagination is more important than knowledge. That's a lame excuse. You're not Einstein. But Einstein was right in that imagination is important, particularly in this space. This is how we train so far. We just keep doing more, and hopefully we go up this competence curve and then plateau out. Well, maybe AI can do this. It can shift that competence pathway to the left, get better quicker, and maybe just get better. And this is from an OR, but this might be similar to our endoscopy suite in the not too distant future, in terms of the automated tools that will be all around: cognitive robots, needle navigation, decision support, and the like. So AI will play a major role in next generation medical imaging. We will need it to deal with the increasing amount of information being thrust at us. It's not going to replace the doctor, but I think even though CAD or computer aided detection won't replace or do the work of the doctor, it should help us do our work better. So with that, I'll leave you and I'll hand you back to Jen.
Great, thank you very much. And I'll get Adrian and Dawn to come back on, and we have a very engaged audience. So I have a number of questions from them. Thank you all for your excellent talks. One of the first questions was, and you can all comment on this, is the utility of using Buscopan to decrease colonic contractions and improve adenoma detection rate or polyp detection rate.
Why don't I have a go at that?
Sure,
I've
thank
not
you.
seen any literature that really demonstrates that it has a major impact. I know I've spoken to the British guys in terms of the British bowel cancer screening program, and I think they were initially using Buscopan routinely on reaching the cecum. And I think the feeling was they thought maybe they were getting a 1 or 2% increase. That would be about it. I don't do it routinely. I do use it when I get to the cecum. If I've had a difficult sigmoid, I've had a fixed angulated sigmoid or a lot of diverticular disease, and I really didn't think there was a lot of spasm, I'll use it to view the sigmoid on the way out. But it's not. I've not seen evidence that's really convinced me that it makes a big impact.
Mm-hmm. Michael?
Oh, God. I'd leave it to these two experts. I'm very erratic with its use. I use it if I get there and I've had spasm all the way, and but I don't use it routinely. I know several of my colleagues at VGH do, and when I hear that they say it consistently helps, I keep saying I'm going to change my practice and do it routinely, and then I keep forgetting. So I just use it haphazardly. I've got no evidence base for it. I'm more inspired rather than foundationally knowledge in that regard, Jen.
Adrian?
I never use Buscopan. I don't think I've ever used it. I don't use it for ERCP. I don't use it for colonoscopy. And I think it was abandoned years ago, but and I thought wasn't there just a paper out of Calgary from Nauser and his group saying that we should not be using Buscopan on a regular basis. I avoid it simply because of the risk of tachycardia and atrial fibrillation and other problems. So
yeah, it was Nazar was, you're right, Forbes is the lead author, but I think it was out of the K clinical, one of the K committees. It was a committee, like a practice guideline type paper that the Canadian Association of Gastroenterology had promoted, and they advised against the routine use of Buscopan, citing, if I recall correctly, I know there was clinical trials done in England, randomized trials looking at Buscopan versus placebo, and there was not an improvement in ADR, and citing a risk of, a concern regarding patients with underlying cardiac conditions. And so they advise against the routine use. And, I as well, in my practice, like I'm quite sporadic in my use. Like I use it on more of an as-needed basis. I find it what I think is the most useful, my perception anyways, I haven't studied this, but my perception is, if I'm removing a larger proximal polyp and there's a lot of contraction, then I find Buscopan can just help settle things down for that. So great, thank you.
just like to add to Jennifer, that I think maybe some of my older colleagues who are now retired probably used it because they thought it would facilitate their colonoscopy and then reduce pain for the patient. Like any of those, I think if you're going to do as painless a procedure as possible, that probably water exchange is your way to go for that. So again, it's just another reason why I just wouldn't use it.
Yeah, I think that we have better means to provide good patient comfort for sure. Another question, and I'll ask this one for you if you have any data on this. So any data on post-colonoscopy colorectal cancers for patients, so the positive fit, negative colonoscopy in terms of neoplastic lesions or cancers, data on what happens to those patients afterwards. And I think the audience member was wondering about how many of those patients go on to develop colorectal cancer. I don't know if that's something you've been able to study yet in Nova Scotia. It requires a bit of a timeline in order to see, I know, but.
Yeah, we haven't, we're like you, we don't really have any data on that yet. We're still sort of trying to track all that down.
Yeah.
Yeah.
We're looking now at just in the process of gathering data for the colon, sort of for outcomes after patients have colonoscopy. So we will have outcomes, the patients who had higher risk lesions had the 3-year colonoscopy. We obviously have more because they had their colonoscopy sooner. But our first full year of our program was, you guys will remember, was 2014. So it was that 2019 was the 5-year follow-up for the patients who had low risk findings. But those patients in 2014 who had a positive and a negative colonoscopy, they're not really due to rescreen they're protected for 10 years. So the real time horizon you should look at to ensure you capture all those events is 10 years. So it takes longer to see that. Of course, we can look and see, and we will, even doing that sort of 5-year follow-up, because we have to wait for those cancers to be registered in the BC Cancer Registry, which is obviously a great resource, but it takes 2 to 2.5 years for that to be complete for that year. So we just now have that 2019 data. So it is something we'll be looking at, but of course we may miss other patients who we feel were protected for 5 more years as well. In terms of other places that publish on that, these post-colonoscopy colorectal cancers, are those are included in these trials. They're looking at, ADR. And so we know that physicians who have a higher ADR have fewer of these positive fit normal colonoscopy and then on to have an instant colon cancer. That's probably all I can really say knowledgeably on that topic. But that was a great question and really important to look at for sure. Okay. ADR, how does ADR change with experience? This is a great question. As someone who's an aging endoscopist, do endoscopists generally improve over time or worsen as their eyesight goes?
Well, I mean, when we first start our practice, we definitely get better. I think all of us can remember our first year or two in practice. And I mean, when you look at we start talking about competencies and you start assessing competency and the number of procedures required to achieve competency, those numbers have gone up and up and up. And they're what the most recent things I've heard, they're in the range of 400-ish before you probably are competent in terms of even cecal intubation of 90%. So there's no question in the early stages, you do climb that competency curve. In terms of the end of your career, I'm not aware of, I've never heard of anything about that in terms of any literature, anybody actually looking at that in terms of eyesight declining or anything like that. The only thing that I've read about, and this might have been out of Doug Rex's group, where they've looked at eye movement patterns, and this might be again related to as we get more experience. Looking at that video that Michael showed of the quality of the withdrawal, it was obvious that the person doing the endoscopy was looking at the lumen only and was not looking at the wall. And the thing, it's interesting watching trainees, they spend so much time concentrating on maintaining a luminal view getting in, and then when they're coming out, they're still maintaining a luminal view. They're not actually looking around and behind folds and whatnot. So this goes back to the whole concept of, better tip control, through scope handling techniques and things like that, and how that improves and works. In terms of your eyesight at the end of your career, I don't know, maybe I don't think my ADR is not dropping. So maybe it's just because I'm doing more stuff, turning and all the things that I never did 10 years ago. So maybe that's why I'm hanging on, even as my eyes go.
Mm-hmm.
There are studies again that show, I forget where I read it, but there has been work that we've all seen, I'm sure, that later in the day, performance goes down, right? So you've been doing a full day, and you probably don't want to be the last call on at 5 p.m. after cranking it all day, and that's human fatigue, and that is one of the suggested benefits of having an assistant. It's not, to me, it's about using whatever tool, or rather tools, to make you better. So that's slowing down, learning the techniques that Don was talking about, encouraging better prep, better tip control, using a cap, using some sort of endo ring or endo cuff splaying device, or using AI. Any of those alone and together should increase. I think it's going to be AI with a cap and bowel assessment for prep to get us better and making us slow down. But one thing that doesn't happen with technology is it doesn't get tired. It gets better with more data. So the more you train something, when we have adaptive AI that works on the fly, it's getting better with each. It's allowed to train itself with every procedure that's being done, which will happen. The FDA is moving towards that. The machines are going to get better. They're not going to get worse. Mm-hmm. And that's really just to make sure that we don't then just get really lazy and just throw the scope in and out. There'll be other safeguards to stop you doing that. Surface area evaluation that somebody's asking about, timing, if you pull the scope out in 1 minute, AI is not magic, but it doesn't fatigue. So I don't know, I like Don, whether, you know, when we get older, whether our eyes go, I'm sure they do. I'm not as good as snooker as I used to be.
I've watched a lot of people do colonoscopy, and we did do some studies looking at year of med school graduation. We don't have obviously the colonoscopist age, and I don't know. Like, I think this is my opinion. Like, I'm definitely like extrapolating out from data and giving my opinion based on it. But I think it's around training. So I think that people who have trained more recently and have been trained in pattern recognition for sessile serrated lesions, that, you know, even during my training in the, you know, the 90s, like, it was just this thing that was just starting to come out. You know, I think it is relative to training. And then there's people who continue to have ongoing colonoscopy-based CME throughout their career, and that's definitely been shown to be, you know, important for adenoma detection rate. So that, you know, as the techniques change, the skills change. And I mean, the sessile serrated lesions were a huge game changer for people whose careers sort of started before that in terms of the very different pattern recognition skills. And I would say, Michael, like, you know, I wonder when you talk about, you know, AI, that you made that de-skilling comment, but couldn't it also train us? Like, it, you know, it trains us for that pattern recognition, just like, you know, when they, you know, there were studies looking at the endocuff, for instance, where people's ADRs improved and they were looking behind folds better, and then they took the endocuff away and they were able to maintain that ADR because maybe the endocuff trained them to look at these areas. So
yeah, I was trying to give a less than biased view about the benefits of AI, about making us, by saying, you know, maybe it makes us lazy, but there's plenty of suggestions, some studies, and actually endpoints in studies being done where we're trying to show the training benefit of AI. And in my opinion, yes, any technology, tool, whatever addition that makes you interrogate or second guess yourself is gonna. So if a machine tells you that that's an adenoma, you know, then maybe the more times it tells you and it's been validated, you'll work out why it's an adenoma with nice classification over a hyperplastic polyp, you know. And again, if you try and tease it apart, I think what people don't necessarily understand, when we look at polyps and we're trying to do an optical biopsy, NICE says look for 3 things: color, pit pattern, vascular pattern. And when people say, how does the AI do it? Well, if you tease these algorithms apart, it's seeing at least 1,000 features per polyp. So we can't even conceive. It's zeros and ones, it's edges and, you know, whatever. So if it's showing you 100 times, that is definitely an adenoma. You're going to get better, in my opinion, as well.
I agree. To come over to water exchange, Adrian, would you mind just going through? I know you had cited that video, and thank you for doing that, because that's always nice to see video. Would you mind just going through with words sort of your process of doing a colonoscopy with water exchange? There's several audience members who are quite interested in knowing the specifics. Maybe you want to try it.
I guess the number one thing is that when you're doing a colonoscopy, you're turning all air off, whether that's CO2 in your unit or if it's air, room air that you're insufflating, and that I usually do my procedures all sitting, so that I insert the scope, I adopt the C course, C loop, I have my hand is underneath, as opposed to over top of the scope, and then I sit and I insert the scope into the rectum and insufflate only as much water as possible to be able to see the lumen, and then you turn with your torque steer as you slowly advance forward. I find that in the sigmoid especially, it just changes the whole way in which I perform colonoscopy. Rather than pushing through blindly, where we used to be trained that, you know, you have that acute angle and you would force through just a little bit to glide by to get around so you could see the lumen reduce. I find that suctioning all the water and air from below then changes the Don talks about putting more air in there, being a more acute angle that's created. Whereas if you're taking all the air and all the water out, what's happening above you is that angle is changing and opening up the colon so that you can kind of turn and find that loop as you're advancing. So I know that there's this theory that the water weighs down the colon. I'm not so much sure that it weighs down the colon, it just changes that configuration. When we get into sigmoid colons, which are stenotic or have lots of diverticuli, and you're using air, that's making those angles even worse. The patient starts to moan and complain because they're having lots of pain because all the air above the fixed stenosis that you're trying to get through is making it harder for the patient. And as time goes on, those things compound your efforts to get through the sigmoid. So by, again, taking all the air and water out as you're inserting the scope, it facilitates that loop transfer through the sigmoid, but also the loop reduction within it, so that you accordion the sigmoid, so that when you get through the sigmoid, it's a straight shot up the descending colon and into the transverse colon. And Don had a nice slide of how he shows that, okay, with position change, you can open up that angle at the splenic flexure or at the hepatic flexure by turning the patient. If you're on the opposite side with gravity, maybe you're going to swing that colon down so you can get through it. And then on the other side, if you turn the patient to the other side, you could swing the colon with gravity and get around that way. Well, I have to say that all those things happen when you take all the air and all the water out as you go. So like I've said before, I never say never, but it's very rare that I turn a patient on their back and on the right-hand side. I used to do it all the time because, I would go to meetings and hear guys like Don talk about it and say, well, that's the way to go. And I found that when I was using air colonoscopy, all those techniques worked. But what I found with, over time in the last 10, 12 years is that water exchange with taking all that air, your air and water out, everything opens up. Sometimes you get into you get past the splenic flexure and you got that deep dive down into the transverse colon, up into the hepatic flexure, and you get your scope in, and that's when all your loops can form. But if you pull back, you get around that hepatic flexure, and you pull back and you reduce everything with your evacuation of all the water and air out of it, that sigmoid colon then accordions and collapses down in your scope so that you get into a straight scope position and advance to the cecum. There's a bit of nuance in terms of how I would, the approaches I would take to advance the scope through difficult colons. There's, people say they use a pediatric colonoscope. Almost never use a pediatric colonoscope, even if I know there's going to be a stenotic sigmoid. If the reason why you're not reaching the cecum is because you have a redundant colon, it's better to have a stiffer colonoscope. And I guess the adult colonoscope is the stiffest. So in that situation, I would use an adult colonoscope almost universally. So again, I don't really have any magic. I can't describe it in 5 minutes. If I'm having difficulty, at most, the position change I'll do is I'll roll the patient forward in the left lateral decubitus position when I'm having difficulty getting up the transverse colon and around to the right side of the colon, and especially redundant colons. But again, almost never ask the nurses to apply pressure. And, the nurses appreciate that. It also helps when, the majority of these patients that I do, like I offer an unsedated colonoscopy to every single patient, and about 70% will say yes to that offer, and about 90% of those will be successful in doing this without sedation. And we have been doing this randomized controlled trial of an extended flexible sigmoidoscopy with water exchange versus air insufflation. We're doing that with Magda and Barry and Raphael. And, we're probably going to stop the study because our endpoint was cecal intubation rate and the differences between them. And before we started the study, we only had one paper that showed an extended flexible sigmoidoscopy with air resulted in cecal intubation rates of 70%. But we're going to stop it because our cecal intubation rate for air insufflation without sedation is 93.5%. And our cecal intubation rate for water exchange is 95%. So even if we do another 100 patients, we're not going to see a difference between those two groups. So, I mean, the benefit of using water exchange in our study has been a decrease in pain scores and a higher satisfaction scores. A lot of 9 out of 10s in the water exchange group.
Which is so important for people coming back, right? Adhering to recommendations regarding surveillance.
Oh,
And
yeah.
I mean,
We're our own worst enemies when it comes to I guess, the reputation that colonoscopy has. But when people go out and they tell their spouse that they had a colonoscopy that was unsedated, I don't have any shortage of people requesting to have a procedure without sedation. But, that's only one of the benefits. I really do believe, as far as adenoma detection rates, which was the talk tonight, that it has enhanced my overall adenoma detection rate over the years. But I agree with some of the comments that Don and Michael has made, is that any technology is probably teaching us as we go along, to the point where you saw on the slide on Joseph Leung, that he's at a point now that water exchange is not making any difference no matter what. I think that probably relates to using water exchange teaches you a bit about the pace of withdrawal required, that maybe AI is going to teach some people, maybe water exchange is going to teach some people. I think probably AI's role will be to maybe add the final layer of how to train us properly to look for adenomas on withdrawal, so that potentially at some point we'll say, hey, you know what? I know what I'm doing. I don't need this anymore. Kind of like Scope Guide. I mean, I don't use Scope Guide. But I think that a lot of people benefit from having it available if they don't have somebody else, who's there to mentor them to how to get through, or how to reduce their loop, or they haven't taken the C course yet. Probably, that's valuable technology. The problem I have with AI right now is it's expensive and it's not available. Those are two small things, but AI also, from what I hear, has a high false positive rate in terms of air or bubbles, sort of bubbles that are left, and stool that's left. So there's a lot of false positives that are going bing, 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 bing on your way out. And if you're not going to spend 2.5 minutes or 2 to 5 minutes to do a water exchange colonoscopy, you sure as hell is not going to be using AI on withdrawal, because at that rate, it's probably going to add in 10 to 15 minutes to withdrawal. That being said, maybe water exchange will facilitate it so you have the cleanest colon on withdrawal when you do implement your AI on withdrawal, right? And to take us to, there was a question regarding simethicone. You don't want to use it.
I was just going to ask that one. Go ahead, Adrian. Yeah.
We don't want to use it in our scopes because of whatever liabilities, and your contract will be, you're not going to get your scope replaced. And there's been issues with certain scope vendors and use of simethicone, and them blaming the malfunction of their image quality on that. We don't routinely use simethicone in Kelowna. Dr. Perini modified our bowel prep probably about 10 years ago. And we include Gas-X tablets with all of our bowel preps. So the patient takes two Gas-X tablets, not to reduce the discomfort of the bowel prep. We tell patients and everybody, the nurses involved, is that it's to reduce the amount of bubbles and do the similar function of having the simethicone in your water. So, our bowel preps are better. Of course, I'm a little biased. And once I reach the cecum, there's pretty much nothing left by the time I turn once I get into the terminal ileum and I come back, there's almost nothing left and very few bubbles. And again, I really believe the adenoma detection rate does go up, and I really believe the serrated lesion detection rate goes up. In the little study that we've done so far, of the 50 patients or 49 patients that I did, 70% had pathology. When you look at water exchange to, compared to air insufflation, extended flexible sigmoidoscopy, the serrated lesion detection rate went from about 11 to 20%. So it does go up, and we didn't count hyperplastic polyps in terms of being a serrated pathology. And one of the things I learned from reviewing this topic is that we probably should include any hyperplastic polyps proximal to the rectum that are greater than 5 millimeters as a significant polyp in terms of recall for surveillance. So the recommendations are to add the serrated pathology proximal to the rectum to the adenomas detected. When you calculate the 5 or greater polyps you're going to need to come back in 5 years. And any hyperplastic polyp or serrated lesion greater than a centimeter is now an advanced adenoma, as is any serrated pathology that has dysplasia. So, it's not just the polyp that has an expanded crypt. You have to have one expanded crypt to be a serrated lesion. If you've got a 2 centimeter hyperplastic polyp on the right side, that's significant. You need to adjust your surveillance. Whether or not that's going to make a difference over time, who knows? And I just want to make one further point. When Michael was talking, it's very important. A lot of the US recommendations look at modeling in terms of when they make a decision on when you should start and stop colon screening. And they don't look at real world data, which is the randomized controlled trials. And let's face it, the best trial, that's why I showed all the flexible sigmoidoscopy data at the beginning to try and put a clinical context into this. This is the best data we have available. And we got 30 years and nobody does flexible sigmoidoscopy. 3 FIT tests 2 years apart is the same yield as a single flexible sigmoidoscopy. The survival benefit for doing a FIT test every 2 years for the next 30 years is the same as doing a flexible sigmoidoscopy every 10, probably every 15 years, based upon this flex sig study that we see. So if you have a normal flexible sigmoidoscopy, and even better, if you have a normal colonoscopy, I know that the positive FIT, but I have a normal colon, what do I do? Well, you probably could wait 15 years based upon the SCORE trial and the other long-term follow-up from the FlexSig trials, because that's the best data we have. Are we going to see, sorry, go ahead.
Oh, I was just going to say, I agree. I think the FlexSig data is excellent, but to the point that you made earlier, there isn't a good randomized trial comparing FlexSig to biennial FIT over long-term, looking at colorectal cancer mortality incidence.
There's not a good trial looking at FlexSig.
There's not a randomized trial. You're comparing it to other data from 2 different trials. There isn't a FIT versus flexible sigmoidoscopy, like biennial FIT versus flexible sigmoidoscopy.
Right.
trial.
So we don't have that
Yeah.
trial. There is one of the colonoscopy screening trials is looking at FIT versus colonoscopy.
Yeah, 3 of them underway. Yeah.
The Nordic is looking at just colonoscopy versus
Yeah.
no colonoscopy.
Placebo,
And I think there was another one, but I'm uncertain as to what the details are of it. But you're right. But we don't have long-term trial data on randomized control trial on FIT. We have it on guaiac-based fecal occult blood testing.
Correct.
Was the sensitivity, does it need to be higher? we were doing a lot of unnecessary colonoscopies, but is that the difference? I don't know the answer to all that.
I'm just going to ask Dawn the simethicone question as well. I'm just interested whether they're doing that in Halifax. Dawn, do you guys do the simethicone and gas X in the prep or in the fluid?
No, we don't, and we've stopped using it. I mean, we used to put it in the water we flushed everything with, but we've stopped. And I know CAG has come out with a consensus thing saying we shouldn't be using it, and I know the manufacturers are too. And I'm trying to remember. I think there may be an issue too with aside from the vision, there may be a problem with biofilm buildup in the accessory channel, and that may cause some potential contamination issues and cleaning issues as well. And I think that's probably the big reason against using simethicone routinely. So, I mean, if we've got a lot of bubbles, we might squirt a little in down the channel with a syringe, but it's pretty rare that we do that. I would put a plug in though, in terms of what Adrian was saying about water exchange. Yes, but if you do position change routinely, you're also sloshing all the water around and it gets rid of all the bubbles. So that's another advantage. Aside from all the other things I could tell you all about. But anyway,
I think these are all additive, actually.
What's that?
I think they're all additive, all of these things. Like,
I think so.
It's not a matter of they're competing. Like we just can add them on. I
totally agree. And that's why I sort of said, we know one, if you do this, you get this. If you do this, you get this. I suspect if you do everything, which is what I would argue is good, high quality technique, that's how you get the ultimate, the best that each of us individually are probably able to reach, whatever that is.
I think additionally, when you start doing water exchange, you probably are closer to water immersion, where you're putting some water in and not really taking as much out. And probably the sort of the last threshold for water exchange is really focusing on taking everything out and collapsing the lumen in front of you, just putting enough water in so that you can see, but suctioning anything in front of you. And one of the things I teach the fellows, because it's when you're a fellow, and I remember it's really hard to give up any real estate that you've already come across. So when you get 10 centimeters and you fall back 50 centimeters, you're like, oh my God, and you're frozen, and you think that you're never going to get there again. But sometimes you have to come back because the air escapes beyond your scope. You come back 50 centimeters, you take out that loop, you straighten it out, you suction everything down, and then you advance the scope forward again. And the constant, especially in that deep dive that I'm talking about, you're not going to get up and over there unless you pull back that scope. And so, the frequent withdrawal on insertion, like Lauren Price used to say, Adrian, you put the scope in the sigmoid and you pull back until you reach.
Pull back to the cecum.
So, I mean, it must be the training in the past, but they all have the same kind of whatever anecdotes. But it's true that focusing on that leads to everything, and you're getting those difficult colons, over time, I can show people if they're there, if they come for the day, and, the best thing is to do one or two, and then let the trainee or the doc practice the technique while I watch. And then, if there's a really difficult spot, I can take over and show exactly what I mean. If the best tutoring is if you can sit there and tell them what to do, and they fight through the difficulties themselves. But at the end of the day, you can show them quicker, and then they just have to go away and practice. And we've talked about what is the adequate number, like how many does it take? I'd say that you're looking at least 100 procedures before you really feel like you're not wasting your time. And like Don said, like every day I go do a colonoscopy, I think it's better than the one I did before. So I think I can get better in every respect. And, I'm looking forward to other technologies like AI to see that maybe this is going to make me perform at a better level. But we need randomized controlled trials to prove that in a real life situation, I mean, look at the Nordic trial. I mean, we have 94,000 patients and 40% were randomized, but only a third of those that were randomized to have colonoscopy in a study actually completed it. Well, your efficacy is already cut by 2/3. That, you know, those patients aren't going to have the benefit of colonoscopy because they just didn't do it. And, you know, that's just, you know.
We're heading over time, and I'm cognizant of the fact that Dawn probably needs to get to bed. It's quite late in their times right now. That was a great discussion. I'm so sorry there were some questions that we didn't get to. My apologies there, but I just wanted to thank you all for coming, our participants. We'll have another session in June on the new surveillance guidelines, and very warm thank you to our 3 excellent speakers. I think that was a great discussion, and I really appreciate your time. And have a great evening.
Thanks very much.
Have a good night. Thanks, Jennifer.
Good night. Good night. Thank you. And good night to all the participants. And please fill out your evaluations, put down, you know, suggestions for speakers, talks that you want. I read all of them, and they do inform the talks that we put in going forward. So please do.